and thank you for tuning in to the Phelan-McDermid Syndrome Podcast, sharing research, progress, and hope. The first genetic testing action day was July 25th, 2025. To do our part, we have two special guests here today who are really tackling the challenges of getting genetic testing done in rare disorders. We have Dr. Sheldon Garrison, a research scientist at Rogers Behavioral Health, who is also on our scientific advisory committee. We also have Dr. Amy Shillington, who is a clinical geneticist and assistant professor from the Cincinnati Children's Hospital Medical Center, who I had the very distinct pleasure of working with when I worked there not too long ago. I would love for them to share a little bit more about who they are and how they found themselves in the rare disease space. Sheldon, want to kick it off?
Absolutely. Well, thanks for having me today. So in addition to Rogers Behavioral Health, I also oversee a biotechnology program at the Milwaukee Area Technical College, where we're really working closely with industry and trying to really make an impact in biohealth. I did my fellowship working with sickle cell disease, moved into pharma, started pharma, working with Phelan-McDermid Syndrome for one of our projects that probably was tied into the organization in the first place many years ago now. And then moved into healthcare for my primary responsibility. One thing that has been special is working with families and people who are affected. There is a young child named Colin Cushman who had Krabbe disease. I was fortunate enough to meet him. He lived a few days past his 8th birthday. And I remember in every conversation that he had with his family, particularly his father would say, if only we knew he had this condition early on, we could have made a change in the treatment plan for him. And I asked myself, why don't we know? And that has literally jump-started the entire area that we'll be talking about today professionally for me, because I was so inspired by Colin. And I think, to me, I can think about that every time I have a conversation in this space.
I think there are a lot of people, sort of that first case or patient you meet that really inspire and sort of drive a lot of our passion if we don't have lived experience in that role. Amy, how about you?
Thanks, guys. Thanks for having me. It's so fun just to talk with you about all the things we think about and the things we're working on. But I'm a clinical geneticist at Cincinnati Children's. I trained there before I became a geneticist in both pediatrics and genetics. I have always had a particular interest in neurodevelopmental conditions like autism and intellectual disability, and how we could use genetics to learn more about each individual with a rare neurodevelopmental condition, so we could inform if there were opportunities to improve healthcare outcomes. So I have a particular interest in working with kids who have a more severe behavioral presentation and who need additional support in the psychiatric inpatient or outpatient setting. So I partner with a lot of psychiatrists, psychologists, neurologists, and developmental pediatricians to troubleshoot personalized cares for these special patients.
So one of the reasons I had you both on today for this episode, because even though you guys are working in different areas, based on your background, you do kind of come to the same problem of under or delayed diagnosis of a genetic condition from different sides. So obviously this idea of underdiagnosis, delayed diagnosis can really resonate with a lot of our community. So how did each of you first kind of become aware of this issue or problem, and how has it influenced your work?
Yeah. So for me, when I started, I was still working in pharma. And one of the things, particularly in the area of the ultra rare conditions, conditions affecting less than 10,000 people. And one of the things we were doing with that drug development is trying to understand the patient population. And as I continued to advance some of our initiatives, realized that we were just not doing a great job of finding out who people were early on. And so when I transitioned into healthcare and began the rare disease research for a pretty large comprehensive system in the Wisconsin-Illinois area, what we found is that seemed to be true for many of our patients, that they experienced delay. And then the just the volume or the number of different subspecialties that they need to go to was making it very cumbersome to get them some of the treatments, particularly early on until they really had a strong treatment plan in place. And so we started to ask questions as a team. It was physician scientist teams, and started to ask questions like, okay, what could we do differently? We started to explore, when could we start bringing in new genetic screens or genetic testing? Could we have a system in place where we could screen people and then move on? And so I think as we were doing that, it made a lot of sense to the physicians. It made a lot of sense to the scientists. But there's still these conversations with the other folks, whether, more administratively, what is the true problem? So we needed to start capturing that. And that's when we started to look at, like, okay, let's define what diagnostic delay looks like for us. And we found some very interesting things that I'm sure we'll talk about in a little bit.
Absolutely. How about you, Amy?
My foray into discovering a lot of diagnostic delays was a little bit accidental and serendipitous in a way. When I was back in my residency training, like I said, I was kind of interested in autism and psychiatry. And so I signed up to do a elective rotation on the neurobehavioral psychiatric inpatient unit, which is by definition is a unit of our psychiatric hospital, pediatric psychiatric hospital, where all the patients who are admitted for kind of behavioral treatment already have a diagnosis of autism or intellectual disability. And I was doing the rotation so I could learn more about how psychiatry takes care of these patients. But on day one, I started asking questions about, what's their genetic diagnosis? What's their genetic diagnosis? And I learned that nobody had the recommended genetic testing for reasons I was yet to understand completely. But quickly, my rotation changed from me trying to learn psychiatry to me trying to teach all the psychiatrists genetics and how to get testing ordered, initiated, counseled, executed on all the patients in the month that I did a rotation on. We were so effective at doing this that the psychiatry was so thrilled by this that they actually, canvassed very heavily to keep me on as an attending when I finished the program. I work as a researcher and I work as a clinician, as I said, in the psychiatric sphere, but in other places as well. Previously, we had almost 0% compliance with genetic test guidelines for that patient population to 100% in that patient population. So we've come a long way there in our very small population. So now my question is, what do we do next to reach other hospitals, reach other patient populations, reach other practitioners, reach other families? And that's what I'm working on research-wise to make it accessible for more families.
I obviously have the personal experience of working with you and sort of seeing that change within the institution. And it truly is incredible to go from 0 to 100% in such a short time. And I know, it probably didn't feel as easy as kind of saying it out loud does, but I think both of you are bringing up sort of this point of there's often institutional and sort of systematic barriers of getting some of these genetic testing done. And so, Sheldon, you've just published two new papers, one in the European Journal of Medical Genetics and one in the Orphanet Journal of Rare Diseases that are really digging into the facts behind diagnostic delays. So can you share a little bit more about what you found?
We need more Amy's in this world because what she just described was exactly what we experience in every place I've ever been. So thank you for that, doing those types of things. The diagnostic delay story, this started again, we're in a very large, high acuity behavioral health care system. So we're only working with mental health and addiction. And we're talking about higher levels of care, which range from intensive outpatient all the way through inpatient. So patients are with us for a very short period of time. And the one thing that we have seen as people admit is they have treatment resistant, medication resistant. And it really sparked this question on our team. Is that because, the medications aren't getting into the bloodstream and being used by the body, so to speak? Or is that because there might be an underlying genetic condition that is really driving some of the symptoms? And until you treat that condition, you're not going to see improvement. And so we started to explore this and literally work through over 6,000 rare genetic diseases. We looked through this list and tried to identify conditions where some of the initial presenting symptoms may be neuropsychiatric. And so, think symptoms of depression, symptoms of anxiety, ADHD. What we were able to do is identify a little over 100 conditions that fit this unique profile and we thought might be present in our system, but undiagnosed. So the first thing we did is we started to do the quantitative piece. So we kind of look at two different things. One, the diagnostic delay showing support that there are likely people in our system who are undiagnosed as they admit. And then two, showing that if we can diagnose them, we'll have a change in patient outcomes. So we'll be able to improve the lives for our patients. And so when we strictly on the diagnostic delay, what we found was shocking. So we looked at it two different ways. One, we had the project that will be coming out soon in Orphanet. Looking collectively, it averaged about 7.5 years from the time the symptoms first began until they get a diagnosis for that condition, get the treatment. The second piece, we did a systematic review, very comprehensive. We looked at every single case we could find for a subset of these conditions, 84 different conditions. And we looked at every single case that we could find and looked at the diagnostic delay. We found cases that ranged from 1958 through 2023, so about 65 years. And we found with these over 1,800 cases, the diagnostic delay was 9.3 years. And that is probably not unexpected by anybody that works in this space. This is kind of common. But what was surprising is that time to diagnosis didn't change between 1958 and 2023. And that was surprising because think of all the changes, think of all the technology, the medical devices, the education, all these really positive things that we've had happen in this space. And yet it seems to not even impact that. In fact, we even looked at the last 10, 20, and 30-year periods just to see maybe with these new technologies, maybe we would see a change. And again, flatline, no change in the time to diagnosis within the patient pool that we worked with. It just made me think we can and should be doing a lot better. And it must be something systematically, as opposed to any one individual person that would be in that patient's care trajectory. So this wasn't, for instance, like providers not like missing things. They aren't. In fact, if anything, they're the ones that are really helping to excel the diagnosis and get the diagnosis earlier. But yet systematically, something seems to be going on. So I think that was probably the most eye-opening finding across the couple papers there.
It's definitely eye-opening and something we clearly need to be doing something about. So Amy, I also would love just sort of your initial reactions to this on the clinical side.
Yeah, in one way, I'm looking at the data and I'm like, oh my gosh, I feel like I'm working every day to push this like rock up the hill, and it's not getting as far as it needs to go. And like, I wonder about those things. The technology is better. Insurance companies are picking up genetic testing, and when I'm like, and I know how important it is, and Lauren, you know how important it is, and Sheldon knows how important it is, and lots of families who then have gone through the process and have a diagnosis know how important it is. But I wonder if there's still like kind of a part for us to communicate why we think it's important kind of in the rare disease community for the places that don't. When we do research with families and with like non-genetics providers, a lot of them don't know what the utility of the testing is still. They're like, okay, well, we can send the testing. Maybe we might get a name for something, but it's not going to change anything we do. And I hear that a lot from kind of developmental pediatricians who kind of deal in this space, or even some psychiatrists. And even when I hear from families is that they are, they're very stressed with like other multiple medical conditions, and they just don't have time to kind of work in a genetics visit or wait for a genetics appointment. And so I think in both fronts, like, is there an educational component where we're like, hey, actually this testing is important, and is that the message that we do in the rare disease community? And certainly some of the work that we just recently put out was kind of describing, well, what changes do we see when we do make systematic changes? We send exome sequencing on everybody who has autism, intellectual disability, and a neuropsychiatric finding. And we do see, impactful changes. again, when we see a fairly high diagnostic rate of around 40% of all the patients that we see in the psychiatric unit that get a new diagnosis, of those patients, 90% had management changes. And so that is a new or different medicine. Maybe it's a new or different health screening because there's something going on with their syndrome over time that we need to check in on, like their heart or their kidneys. Maybe it's a medicine you might avoid because they have a mitochondrial disorder, and some of the medications can be kind of more damaging to mitochondria that we use for epilepsy. And we also see that our kids who are in the diagnosed cohort have shorter stays in the future. So once they get a rare disease diagnosis, we calculated all the inpatient hospital days they had the year before their diagnosis and all the hospital days they had the year after their diagnosis. And they had, on average, 22 fewer days in the 12-month period after they had their diagnosis. So, we're saving time for the family, we're saving money for the family, we're saving money for the system, and we're reducing stress for the family, right? We see that there are actual behavioral changes. So when someone has a new diagnosis, we're changing their medication management. So perhaps their medication is better, they have fewer behavioral challenges, they have fewer inpatient admissions. Clearly, it makes sense. I also think that family stress is reduced. If they are kind of on this journey of unknown, and now we've given them something known, and we've given them a community, and we've given them a support group, then, they have that support for that stress. And we know that family stress leads into psychiatric inpatient stays as well. So, there are a lot of areas why having a diagnosis kind of improves the big picture for the patient and the family.
That stat alone of those individuals who received a genetic diagnosis, 90% of them then receiving change in their treatment management is incredible. I know you've been able to shout that from the rooftops at numerous places, but it's almost like we really need that number, that stat to be out there even more, because I think, like you said, the amount of times, I've heard from families, even physicians, just sort of not understanding that treatment can change with a genetic diagnosis is so important. And you obviously also bring up that community piece. Our Phelan-McDermid Syndrome Foundation community is so strong because they are them.
Yes.
And that's so true in a lot of these other rare disorder communities that until you're in it, I think it's probably hard to imagine how much the community is helpful and how it can really actually then impact quality of life and probably further treatment care, because then you're talking to families who, oh, my kid went through that 2 years ago, here's my suggestions, it just sort of builds on each other.
We saw almost the same result. So the systematic review where we were looking at the 1,800 patients that I mentioned, we found that approximately 80%, once they got the diagnosis and they got a treatment plan that was tailored to the underlying rare genetic disease, over 80% of people improved. Just at least one of their symptoms significantly improved. So we came up with not just the same conclusion, but it sounds like similar stats when it comes to that.
Well, and I think replication in science is always important, but I think the fact that they are a little bit different, but sometimes overlapping populations really speaks to the power of genetic testing, and that it's not just one provider who has a lot of knowledge that is going to be able to change the treatment plan. But it's not just the Amy's of the world or whatever that are able to adjust treatment plans. This is something that with that genetic testing result in hand can really change what your methods and treatment plans are. I did want to go quickly back, Sheldon, to that review paper, because I know there were some SHANK3 patients in there. Was there any difference, or what was that average diagnostic delay for our specific patient population?
So the largest group that we saw was over 200 people, I believe, and the average diagnostic delay was 5.9 years. For PMS. And when we looked at individuals with a systematic review, the time to diagnosis was much longer, but that was only 12 individuals. So I think really that nearly 6-year diagnostic delay was telling. Certainly the range, it can be quite large within our area of Phelan-McDermid.
I mean, it's nice to hear on average that it's a little bit lower than kind of the overall average. But I mean, you obviously speak to that range. And, I've been here now since December and meeting families who, have gotten their child diagnosed as young as 1, which is really incredible. But then I'm also hearing about individual diagnosed until their 40s or 50s. But again, 6 years is still a really long time for families to wait. So I think this is a nice segue to also continue to dig into where Amy has been doing a lot of research. She has current funding through Cincinnati Children's to help identify barriers to genetic testing, both from the provider side as well as the patient and family side. So I'd love to hear a little bit more about kind of how this came about and where you are.
So sad that you're not on our project anymore because you were obviously a super great asset, and we're trying to fill your shoes. We've been researching barriers to access to genetic testing and genetic evaluation across the whole institution. And we have been looking at doing a huge data poll from the last 20 years of referral patterns in our institution and genetic testing outcomes for patients and how providers experience that. So we're 2 years into the project, and we do have some preliminary numbers. So I guess this is hot off the presses. So and not yet peer reviewed. So I guess stay tuned for that. So right now, one of the things we notice is that there's kind of a pretty long wait time to see an outpatient geneticist, and I think that's probably true across the country. At our institution, it's 182 days from someone to put in a referral to genetics for a patient to be seen. That's average. Some people wait a lot more. Some people get lucky and get, a last minute appointment, but that's 6 months. So it's not, 9 years like Sheldon is saying, but for families who really do want that referral and who are, really wanting to get information and are feeling stressed, waiting 6 months to get in is challenging. And we also learned that for every patient that's being referred to genetics, so when a provider is like, hey, I think you would benefit from a genetics evaluation, only 66% of those people make it to an appointment. So a whole third never even make it. So something's going on, and we're trying to understand, is it a system problem? Can they just not get in? Can they not get in at a time that works? Is it inconvenient? Can they not travel to us? Or is it a family problem? Are they stressed? Are they prioritizing things differently? Would they rather see a GI doctor or a psychiatrist? And those are like higher concerns right now, and kind of genetics gets put by the wayside. Or, do they have a transportation barrier? Do they live far away? Or is it really difficult to bring their child into a lengthy genetics appointment? Our appointments are like an hour and a half long. They have to sit in a waiting room. They have to sit in our clinic. I mean, that can be really difficult for a kiddo with a rare disease. And so families, again, might prefer not to do that. And so we're still collecting kind of patient experience surveys right now to explore what the barriers are that families are appreciating. We do see all of the things that I hypothesized. We do see all of those things. People are reporting back on all of those things. And so we're trying to think of ways to create fewer barriers. So more telemedicine visits for kids in special populations so that they don't have to travel, don't have to sit in waiting rooms. They don't need to do invasive blood draws. We're getting spit kits to them, things like that. And the other thing that we're trying to do is to try to get more genetic testing initiated outside of the genetics clinic so that you don't have to see a geneticist to get genetic testing. And so that's one of our initiatives too, which is complicated, but we're working on, how to educate developmental pediatricians and psychiatrists and neurologists and primary care doctors, like, hey, you start the genetic testing and then refer once patients have tests in hand so that I can, or my colleagues can kind of come in when patients already have that testing back. And so that reduces that wait time to genetics and kind of, gets testing cooking, so to speak.
Right. And I know this is just hot off the press, and so I have a million questions, but I'll try to narrow it down to one, and you might not have the answer. Is it always either the delay time or the number of people who are then missing genetic testing?
So we actually did look at some comparison populations of epilepsy and neuromuscular or hypotonia conditions. And actually the wait time and the loss to follow-up rate is the same. So there is something about the way either our patients are thinking about genetics or the system and how people kind of get into a genetics appointment that applies to kind of all rare disease. It's not kind of unique to neuropsych or neurodevelopmental conditions.
The American Academy of Pediatrics did just update the recommendations specifically for individuals with intellectual disability. in global developmental delay. So I'd love to hear from both of you about sort of like thoughts on the provider side of things and where some places things could change there.
We did survey providers at our institution about kind of their experience with ordering their own genetic testing. There's new guidelines. If you meet the indication, you have intellectual disability or global developmental delay, the recommendation is to get genome sequencing or exome with a microarray, which is kind of the equivalent. So the test is the same. It's big and broad. The indication is fairly standardized. So like we've removed some of those barriers of uncertainty about which test to order, right? So that's great. However, when we interviewed providers, we found that there are kind of two areas that they felt the most discomfort with. And one of them was on consenting for the test. So we know that exome or genome sequencing is a big test. There's implications for kind of secondary findings. So things such as adult onset cancer conditions. Some providers are just not comfortable not having the training in doing consent or thinking about those implications. There are implications for kind of long-term disability insurance or life insurance. We do these tests as a trio. And so with a maternal sample and a paternal sample. So sometimes we can learn something about a patient that we also learn in a parent, and the parent may or may not want to know about that. So the consent actually is for all three people that might be participating in the study. The other concern that providers had was what to do when the results come back. These big genomic testing have a lot of variants of uncertain significance. So we can get a positive finding, clear cut, here's your condition. There are guidelines probably in the literature for many conditions. It could also come back completely negative. Okay, great. We did the testing. We've ruled it out. Now we can kind of keep focusing on symptom management, knowing that we're not missing a rare disease. But the stuff that's gray and in the middle is a variant of uncertain significance where we just don't know enough about that gene change to say this definitely causes disease or doesn't. And so our providers that are not genetics trained don't feel confident or comfortable knowing what to do with that type of result. There is that type of result in a lot of testing. So for those two reasons, because the consent is too complicated and the interpretation is too complicated, a lot of them will prefer not to get the testing started. So our work is like, well, what do we do to help them with both of these things? So what we've done at Children's is we've made a virtual consent video, a freely available YouTube video about consenting for genome sequencing. It has information for the patient, it has information for the provider. So that's freely available for anybody. And we try to share that with everybody so that they can use that tool. The other thing we're doing is creating kind of streamlined clinic follow-ups. And so we have dedicated genetic counselors with held clinic spots. And so we're trying to bridge the gap to that longer wait time to help people feel confident that the results are not just going to be floating out there in the ether without somebody to kind of have their backs. And so those are two of the things we're trying to address to give people more confidence that they can use and order this testing.
Amazing. We'll have to definitely provide that freely available video in the show notes. Sheldon, what are your thoughts on this? And like, how has your work matched up with some of these things that Amy has been finding? And kind of what other things are you looking at?
Yeah, I mean, I would say I agree in most of my conversations, the uncertainty, how do you manage the patient next? Who do you refer them to, particularly in systems I've worked in that aren't comprehensive, so they might not have a staff neurologist. And so like, what are your next steps if you find out this information? So that's a barrier. The other thing I think when we hear the term rare disease, for those that don't work in this space, we all live and breathe this space. So it's just so obvious to us why it's so important. But for those that really don't work in that space, I think it's challenging for them to really champion, support some of these endeavors, particularly those in more of an administrative role that are key partners for us. And so one of the things we've done to try to address that is show the financial implication. Our team, our first step was to look at the healthcare economics of rare disease. We looked pretty broadly, and there's limitations to how you interpret any of it. But what we found is nearly half of all of healthcare costs were attributable to people with rare conditions, and so that's treatment for anything. It could be a broken arm or it could be treatment for that condition. We found this disproportionate cost. And what was interesting is there was a couple studies that with unrelated teams that came in right after and showed very similar data. And so that really kind of supported this idea. This is a really big deal. It's at that time that I personally found that people start to listen because they understand that there's large financial implications if we don't treat something. If we don't diagnose something, they're probably going to utilize more resources. So I think from that standpoint, it's really helped to elevate the conversation to the right leaders, I think. The other thing, and this is again the paper in Orphan that was just accepted, we were able to look a little bit more closely on psychiatric related inpatient admissions. And what we found for the small group of 100 conditions, $2.5 billion spent for psychiatric related inpatient admissions annually, and about 70 million on emergency medicine visits. Once that information starts to circulate to people, they see that there is a more holistic need to start addressing it. We really need that system approach. And I think that's helping us to really create that case that we can and should do something different.
Both of your work mesh together so nicely of, you're sharing this economic burden of, for instance, inpatient unit costs and ER costs. And Amy is showing, well, if you get the genetic diagnosis, they're staying fewer days, they're having fewer readmissions. And so she's like showing that economic benefit then of what's happening. One thing we haven't talked about yet, and something that I am particularly interested in my role, is where do patient advocacy organizations fit into this? How can we help move this along?
Well, this podcast certainly is a nice start for sure. I think continued advocacy, patient stories are always helpful. The patient stories tend to be the ones that kind of shift the needle to moving research, moving funding, moving policy forward. And so if there are families in the Phelan-McDermid community who want to advocate for PMS or even just broadly for rare disease, I think that is such a value.
That patient voice is so incredibly powerful. One of the things that we rely heavily on is that interaction with different patients or patient advocacy groups. Those organizations are really at the center of what's most important to those who are affected and their families.
We know our families are the biggest advocates for their loved ones. And so I think this is just one other place that they can really kind of be loud and, be loud with your friends and family members too. Anything else you want to share on this topic that we might have missed, or you want to make sure our families and listeners hear?
Sure. One thing, I think one of the reasons why I've enjoyed being part of PMSF is that I think it's a true model organization. And I'm not just saying that. I think it really is. And I think that hopefully it provides an openness and opportunity for other groups to really learn from some of the things we've done. For instance, getting the ICD-10 code recently was a big deal. In part, that's what pharmaceutical companies, that's what researchers may use to try to understand the patient population, get the information that's going to allow them to have those conversations to promote whatever project or initiative they're working on behalf of those affected by that condition.
I would just say this is not a shameless plug or anything. The next subspecialty clinic that we have in neurobehavioral psychiatry at Cincinnati Children's is a Phelan-McDermid clinic. So that will be exciting and launching this fall.
We are so excited for that. And yeah, definitely listeners, stay tuned. We will be sure to have an announcement about that. And then probably a visit for me later in the fall.
Woohoo! Yay!
Helps when you live in the same city. Thank you guys both so much for being here. I know we sort of only scratched the surface on this topic, and I hope we can continue this conversation soon. And hopefully we can both get you to come out to our 2026 family conference in Aurora, Colorado next July.
Cool. Can't wait to see you guys there.
Yeah, we will see you there.
All right. Thanks again. And stay tuned for the next episode, Phelan-McDermid Podcast. I'll talk to you everyone later. Bye.